As we're getting into a conversation this morning, the Senior Deputy Director at the Ministry of Health, Dr. Sultani Matendechero, joins us again in the hot seat of the Situation Room this morning. Dr. good morning.
Good morning. How are you doing?
Very well. How are you?
I'm fine.
You seem very relaxed. And there seem to be fires all over the place.
No, I think maybe I'm relaxed because of the comfort of the seat.
Okay.
Yeah.
Okay.
So it's a good departure from the fires.
The fires that are around you normally. Well, okay, we're going to get into some of those this morning. So you might want to, maybe have something cool just around you. And I'll tell you what that cool thing could be later. But hey, as we get into the conversation this morning, CT, as you know, normally has a proverb every morning. He wants to share that with us today and tell us where it's from. And then maybe you can interpret that for us and tell us what it means to you. Okay.
Yes, our proverb for the whole of this week come from a country that once was part of a massive, extensive and marvelous empire. It was then called the Mali Empire, but now it's called the Republic of Mali. The proverb: the kitchen is older than the mosque.
Okay, so you want me to interpret that?
Yes.
Yes, please.
Okay. So where I come from in Lydiah land, we usually say whatever the circumstances, eat fast. So probably it is related to that, because before you even go to the mosque to pray, maybe you need to eat so that you can have the energy to go and pray. So I think what it's just saying is that in life we have quite a number of priorities, very important, all of them, but you have to know how to rank them so that, you are able to carry them out in a way that enables you to do everything
right.
you need to do.
Yeah. Right. Indeed. There's it.
Excellent interpretation.
Fantastic. All right. On a good start, and then getting into some of the things that we need to discuss this morning. We've alluded to the fact that there are a number of fires that seem to be burning and at the same time. And let's start off with SHA, obviously, because it's the elephant in the room and it's about to give birth to another elephant from what we are seeing. What exactly is happening? There seem to be a number of things here. And if we look at the 4 tiers of funding within SHA, when we look at your primary healthcare, which is paid by government, and then we go and look into your healthcare that would seek for admissions and surgeries and things like that, which is paid by premiums that Kenyans pay. And then we go to the 3rd tier, which is critical and chronic care, which then again is taken care of by government and or donors from what we have seen. And then you have your civil servants cover, which then takes care of teachers and police and such. So those, we understand, all come under the Social Health Authority. But it seems at some levels something is not working. We've seen that from the Director of Health, whereby there would be a nationwide recruitment, and recruitment in this case is for more folks to come into the pool via the payment of premiums. But that doesn't seem to be working all in tandem as it was originally designed. So I guess the big question here is why, and what's going on?
Okay. Yeah, so I am impressed with your level of knowledge of the whole structure around SHA, because that's one of the biggest gaps that I've observed in the conversations that are going on. People don't seem to understand, first of all, what this SHA is all about. Sometimes you hear them saying, this shisha. You wonder, but shisha is something that people smoke. And it has even been outlawed, So, but it is good to hear that someone actually has a very good understanding of what SHA looks like and what it involves. But maybe just to put us in context, I would just like to say that all these things are tied to a constitutional provision that we need to make sure that all Kenyans are having access to the highest quality of health attainable, as a constitutional right. So it is imperative that we come up with mechanisms and policies and strategies on how to provide that highest standard of healthcare to all Kenyans. Now, one of the most important pieces that has to fall in place is how to finance these high standards of healthcare, which will be affordable to all Kenyans. And the silver, what do you call it? The silver bullet. Here is SHA. Without SHA, we are not going to achieve universal health coverage. Without universal health coverage, Kenyans are not going to access the highest quality of healthcare at an affordable cost, at least the majority of them. So we are now moving from a place where we were working with the National Health Insurance Fund model to this model that you have just described, the SHA model. And of course, it's a big shift because now we are looking at moving from just covering a small proportion of the population to covering everybody in the whole population. Now, the challenge has become this shift that we are trying to make. Because, of course, with such a shift, you expect that there'll be a bit of turbulence, in the beginning for some time, and then now things stabilize. But from where I sit, I see that we are spending quite a bit of time, much more time, in that area of turbulence. And that is now what we are trying to interrogate. Why are we spending so much time in this area of turbulence? And then number two, the more we spend time in the area of turbulence, the more we tend to start feeling that we are going in the wrong direction, we need to go back. In fact, now I can hear a lot of voices saying, SHA is not working, we need to go back to NHIF. But the fact is that if we are talking about universal health coverage, then NHIF is not an option. We have to all come and put our heads together and see how do we make SHA work and how do we stabilize it as fast as possible. Yes.
So how do we make it work?
So I think, and that's an excellent question. Actually, one of the things that we have to understand is that what is the basis of SHA? The basis of SHA is that we want everybody to contribute. Everybody. It doesn't matter how much you're contributing. Yeah, you might be contributing a bit more, you might be contributing a bit less, but then everybody is contributing. And this contribution, when it goes into a common basket, now we are able to collect an amount of resources that is enough to finance healthcare. So you'll find that some people who are earning much more will be contributing more. Those who are earning less will be contributing less. It even provides for those who are not able to contribute, because some of the people are earning very little, and if you take away from them, then you actually drive them into catastrophe. So for those ones, the government has come up with a mechanism of paying for them, so that whereas they are not the ones who are paying, but at least there's someone who is paying for them. We call them indigents. Yeah. So these indigents are not able to afford to give their premium. So that way now we say everybody is paying. However, one of the biggest challenges is that we are seeing that quite a number of people have not yet registered. Yeah. So that is the entry point, that everybody has to register so that they can benefit from the SHA process, but at the same time so that they can be enabled to pay. Now, out of those who have registered, a very small proportion are actually paying. So you see, that's the first challenge, because we are not able to now mobilize the kind of resources that we need to finance this healthcare. Number two, the facilities that are providing healthcare services now need to get into contracts with the SHA, because previously you'll find that it was NHIF, so there was an arrangement with the NHIF. Now, this is a completely new arrangement. So we are expecting that for facilities to be recognized and for order, then there must be a contract between the facilities and SHA. Now, we are experiencing a bit of a difficulty because quite a number of facilities have not gotten into that contract. So they are not able to provide the services under SHA. And when people go to those facilities to be treated, they are not able to access the services. Now, there are other challenges that maybe we can just group together and say others. Yeah, we have experienced situations where at individual level, some people are reluctant to play their part in making this SHA work. I'll give you an example of someone who was telling me a story. I don't know whether it was a fact or maybe they were just making it up. That a friend of his, is affected because the wife works in NHIF.
Yes.
Now, NHIF, as it is, has about 1,700 employees thereabout. Yeah. Now, one of the things that is one of the major touch points for SHA, because we are also trying to see how we can introduce efficiency. We want to move away from the inefficiencies that were there before. One of the touch points is to now ensure that we have just enough employees. So we are looking at reducing these employees from 1,700 to something around 800, between 600 to 800 there. So we are already seeing that about 1,000 jobs, if you look at it that way, are at risk. Now, these employees are wondering, am I going to make it, to this transition, or am I going to be among those who will not make it?
Yeah.
So the interpretation now becomes that, some people who are worried of losing their jobs might actually be just sabotaging the process, so that it looks like this SHA is not a very good idea. Let's just stay with NHIF so that, we can retain our jobs. Now, another thing that, because now we are trying to understand what is the problem, why is this thing facing a lot of headwinds?
Yes.
Another thing that is coming up is the possibility that, in the past, under the NHIF, again, just inefficiencies, the facilities worked with something called benefit packages, where we would say, if you have a headache, what is the maximum amount of money that you will need to treat that headache? Now, remember, headaches can... I'm just using that as an example. I'm not saying that is what was happening.
Yeah.
But, remember that headaches can come due to very many reasons. Some of them might just come because you are anxious. You are anxious
in the moment,
and you start having a headache, tension headache, and you don't need to even treat it. You just need to relax and it goes. So, you might not need to spend anything. Others might just need, you take some paracetamol and you're okay, just 10 shillings. But there are some headaches which might come because of a tumor. And you might need to undergo treatment worth millions of shillings. So you see, it is a whole range from 0 to millions. So you'll find that maybe a benefit package which was capped at 100,000, somebody is coming in with a condition that is covered under that benefit package, which actually just needs about 10,000 for treatment. However, when claims are made, they are made at the maximum, 100,000. So you start seeing facilities really growing very fast, and you're wondering what is happening. This is a very lucrative business. But it is because of those inefficiencies, because now we are funding infrastructure, we are funding the growth of private facilities and so on, instead of targeting the patients and the sickness.
Right.
So what SHA is trying to do is to say, let us look at the majority of these people. Where should we cap? If we cap it at a certain point, are we going to capture 80, 90%? Then these 10% who require very big amounts of money for the same condition, we can now be able to look at them more keenly under the emergency, chronic and critical illness fund. So you see, this one now kicks in to make sure that even if you have a tumor, we will be able to fund the treatment of that headache completely.
Right.
But now under a different arrangement. Whereas we are now managing these other simple headaches, we are also managing the complex one.
Okay.
So what happens? The few, because these are now few, they are not the majority, they are the minority. The few unscrupulous providers who are benefiting from those packages start crying wolf and saying, no, they start creating a lot of confusion and, and saying, this thing is not working, it's so bad, we need to run away from it, because they do not want to now suffer the consequences of these benefit packages. So those are some of the issues that we are looking at. There are quite a number of them, but we are hoping that if we can have good conversations and engagements, then we should be able to address these issues.
How much does the government budget for healthcare provision in the country?
So when you look at it in terms of consolidated fund, because Parliament appropriates for healthcare, there is what goes to the national government, but then there is also some resources that go to the counties, where now the counties will be expected to appropriate again towards healthcare. But roughly you can put it at around 120 to 160 billion every year.
That is what is budgeted for.
That's generally now an approximation of what goes into healthcare.
Okay. Yeah. When we talk about primary health care, what is it that we think we would need in a year to provide adequate health services in that particular sector of SHA?
Okay, of course we need a lot of resources. Now, unfortunately, I'm a technical person. For me, what I really go into is to look at how do we manage these outbreaks of leishmaniasis and MRSA and so on. So when we now go deep into the provisions of resources,
don't worry,
then it becomes a little bit
I will leave
difficult.
that alone. Now, let's go to the chronic and critical care.
Yeah.
A certain amount. There's a reason why I'm asking the question.
I know, yeah.
You do know.
Yes.
I'm simply saying this. Are we suggesting that what the government budgets for healthcare, because that budget is what is cascaded to the counties, it's not as though there are 10 other budgets, it's the same budget. Is it adequate for the needs that we are saying SHA hopes to meet?
No, what the government is budgeting is not enough.
Precisely.
Yeah.
If it isn't enough, the burden that the government has pledged to carry with regards to SHA, does that budget cover what it is that is then required if we look at what the government is supposed to actually cover?
So when you look at the plan that is in place, that's what it wants to address, so that we can raise adequate resources to be able to take care of the various funds under SHA. Remember, as Ndu correctly put it, we are looking at two, forget even about the fourth one, the civil servant scheme and so on. Actually, the main funds are the three. Because when SHA is fully functional, we don't want to have anything like special schemes for civil servants and so on. Everybody is just supposed to access quality healthcare, whether you are a civil servant, whether you are a street boy, everything, whether you are a business magnate, everybody is supposed to access the same quality of healthcare at an affordable cost. So the three funds are supposed to now address that issue that you are talking about. The primary healthcare fund is extremely important, and I think that is something that probably we are also not explaining very well, because you'll find that the primary healthcare fund is targeting issues around health promotion and disease prevention. That is an area that we have, I don't know why we have run away from it for all these years. Because what happens is, if you focus and invest in health promotion and disease prevention, then you are going to drastically reduce the number of people who are going into hospitals to seek treatment, rehabilitation, and palliative care.
And that's where all the cost really is, isn't it?
Yes. So you see, primary healthcare fund is not just about allocating money to go into the usual same old treatment. It is about allocating money, investing in a paradigm shift, where we are going to now, and we have to spend money. We have to spend money. We keep on thinking that if I come to Spice and I say, wash your hands, then people will wash their hands and the disease
and
will
then
go
we're
down.
fine.
It won't. We have to invest in effective interventions, which are now going to ensure that we are promoting health and preventing disease. Then the numbers drastically go down. So what we need for treatment drastically goes down, and it becomes affordable. Now, the government is going to take care of primary healthcare fund. Now, I just explained a little bit about the whole issue of the emergency, chronic, and critical illness fund, which also has its very special role in making sure that we bring efficiency into the shift. Now, these three funds that we are talking about, primary healthcare fund, emergency, chronic, and critical illness fund, especially those two, there was a plan on how to raise those resources, because there are a lot.
Okay, let's talk about the plan.
Yeah.
I'm interested in the plan. The reason I'm interested in the plan,
Yes.
that plan, when activated, should solve these problems, isn't it? So, do you have knowledge of the plan?
Yeah.
Okay, let's hear it. What was the plan? How is it supposed? Because the truth of the matter is that this ambitious project cannot be met with what we normally do regularly.
Absolutely.
Because if the other day Parliament proceeds to allocate 1.8 billion for primary health care, you look and you say, whoa, do these people know what they're talking about? What are you supposed to do with that amount? Anyway, what was the plan?
Yeah.
Okay, good. So the plan was that let's be able to allocate sufficient resources to primary health care.
Yes.
Let us also allocate sufficient resources to emergency, critical and chronic illness fund. For primary health care, we were actually looking at the possibility of being able to allocate sufficient resources for everybody who requires these primary health care, which is mainly health promotion, disease prevention, which are usually provided at the level 2 and level 3.
Yes.
Okay.
Level 1, 2 and 3. So level 1 is the community level, where we have the community health promoters, the community health assistants, and generally it's a household-based kind of level.
Yeah.
Level 2 is mainly the dispensaries, you know.
Yeah.
And the dispensaries are usually like offices for these community health promoters, where they get their refills and, coordination and so on. But if somebody has a minor ailment like malaria, uncomplicated malaria, they can be able to get
They can
some
be
treatment
sorted
and
there.
go back home. And they can also get information. The community health promoters actually are the main drivers of health promotion. Now, level 3 is the health centers, where if you have a simple ailment, before it, sometimes early treatment is a very important form of prevention. It's actually like secondary prevention. So that if you fall sick, say like now malaria, you don't stay with it for very long, because you'll start infecting other people.
Yes.
So you now quickly go in and you are treated before it is too long. So it is too late. So this level is the one that really takes care of the bulk of primary health care. And the plan was that we give enough resources to these levels, the level 1, 2, and 3, so that people can just walk in. So long as you are registered with SHA,
Yeah.
you just walk in, you get the services, you go back home without any kind of payment.
Right.
Okay?
That's the idea.
Yes, that's the idea.
That's the
And
plan.
it is a very expensive idea, unlike what we think. Because science has shown us, actually studies have shown us that for every shilling we invest in primary health care, we will save upwards of 9 shillings that would have gone into treatment, rehabilitation, palliative care.
Okay.
So that is a very good investment. In fact, if this country wants to grow economically, that is one of the things that we should not let go.
Okay.
However, unfortunately, and this is something that is really unfortunate. In last year, when we were now looking at being able to raise the money that should go into primary health care and these other funds that we are talking about, we all know what happened in June, the finance bill. It failed. So that instrument, that finance bill, that instrument that failed is the one that was supposed to raise this money. And you remember, the biggest complaint was that now we are overtaxing people and whatnot and all that. But the truth is, it was necessary to overtax, using the words verbatim, so that we can raise these resources. Because if you are talking about, say, 70 billion additional to go into just primary health care, you really need to find ways of raising that money. So when it failed, we were not able to move with the primary health care. We were not able to move with the other chronic and critical illness fund. But, government doesn't say that because the finance bill has failed, now we will not provide services. You have to look for some way in which you can do some patchwork to ensure that things are moving.
I wanted to take a break, but I think at that point is where you now say, but
Yes.
then how do you then do the patchwork where you have people who are sick today, where you have people who need healthcare today?
Right.
You also have people who have been paying their premiums diligently, month on month, year on year. We say that prevention is better than cure. It's been said. And so preventative care is one aspect that's being looked at. But if we looked at the practicality of some of these things that we're asking about now, when people say SHA is not working, we're looking at the case of Ariana. This baby passed away, but her mother has been making her payments religiously, even when it was NHIF, and continued to do so when it is under the authority. The baby is gone. She's left with a bill of 1.6 million. The authority has paid 23,000 shillings, which is not even a drop in the ocean. It's not even a bit of sweat, moisture. So how then do we deal with that particular issue when you say, okay, so but I've been contributing?
Yeah, so that's a very pertinent issue because, I really, it's really sad to hear that story of baby Ariana. You know, those are now some of the practical challenges that we are looking at. And as healthcare providers, the worst thing that can ever happen is to lose a patient because, once they die, then the challenges that you are trying to address, by the time you finish addressing, you cannot now go back and say, okay, now we have fixed everything, so wake up so that we can continue. So, and of course, my very sincere condolences to the family. Mm-hmm. Now, that is a challenge that is facing a lot of people, including myself. Mm-hmm. Yeah. Before we moved over to SHA, I was being deducted 1,700 per month towards NHIF. And right now, when I looked at my payslip, I was last month this month I'm going to be deducted 15,000 shillings. Yeah. Now, if I fell sick today and I went to, let me not name hospitals.
Okay.
But a hospital that I probably would want to go to, a nice private hospital. Yeah. I have practically been to a hospital and I'm told we are not taking SHA. You know, for those reasons that I talked about, some of the hospitals have no contracts. Some of the hospitals have not been paid. They are having bills. You know, all the way from NHIF. They have bills. So they have said, I am not going to continue providing services unless I am paid those bills. So you see, I am paying much more, but now I am not able to receive the services. And those are some of those choke points that I was talking about, the turbulence that we are seeing. Of course, there are some other, on the other hand, there are some other experiences, and I can even show you messages, people sending to me, telling me, this SHA is really good. I went to the hospital and within minutes, we had already received authorization and I was treated. So a lot of those ones, we don't hear about them. But then these others that are very sad, are the ones that we hear about a lot. So those challenges that we are spending so much time trying to address is what we really need to now put our heads together. And I think one of the things that I keep on saying is we have to also reorient our mindset because implementing something like universal health coverage is not an easy thing. It's a very complicated thing. It is it requires a lot of resources, it requires a lot of planning, it requires a lot of efficiency, and we all have a part to play in it. Now, when people are trying to do such a complex, when they're trying to implement such a complex shift, most of the time we will start getting frustrated along the way, and we will start looking at each other to see who can we blame among ourselves, so that we can now apportion and say, you are the one who is responsible for this mess, you are the one who is responsible for these troubles. But the solution here is that we have to reorient ourselves, we have to take a break, look at things, see how can we all participate. And it is a global thing. Universal health coverage is not easy. In the global north, it's possible because they have quite a bit of resources available for healthcare. In the global south, it is very difficult. So we are still having those challenges, and we are really looking at who do we blame for these challenges, who is responsible, and so on. We need to rethink around it and say, how can we change our discourse so that everybody participates? How you should be asking yourself, as a journalist, how can I contribute towards making making this work faster.
Okay, this is what I'm going to do right now. I am going to contribute.
I'll ask after.
Okay? Dr. I'm going to do exactly what you've asked.
Okay.
It is true.
Yes.
Very few countries have been able to actually institute a program that you can refer to as universal health. Start with a roadmap. Not piecemeal information about it, a roadmap. We began and we piloted with 5 counties. Was it 5? Yes. We knew there was a pilot.
Yeah.
There were results from the pilot. The consistent and constant communication about the process got lost somewhere along the way. So you don't even hear. When you pilot, the whole purpose so that you can cascade it to a larger number. From 5, maybe you go to 15. From 15, you go to 25. So that over time, there's a roadmap that by the time we get to this, we'll have gotten to 40 or 47. So people know as you're thinking. And any time that move is made, you announce it or you tell people the path. So now, when you talk about universal healthcare right now, most people have no clue what it is you're talking about.
Absolutely.
Because that conversation was not maintained.
Right.
That's one.
Okay.
Let's come to primary healthcare. The preventative aspect of healthcare as opposed to the curative, which we know. Anybody who understands anything, no matter how minute about health, knows this is the way to go.
Yeah.
Do we know the diseases that people present when they are at that level where they go to a dispensary or when it is that they go for what may be primary health care? Do we know? We do know. We do know the ailments that ail people, as we say, generally. We do know. And we do know, for instance, malaria. We know people get malaria. We know people get pneumonia. We know people get diarrhea. We know. Now, these are diseases that can be managed at that level that you are talking about. Easily. When they mature and you've taken them to the next level, now that's a completely different story. The amounts of money that Ndu was talking about then come into effect because ICU may be around the corner. Do we have a roadmap where it is clear that when you have these community health promoters, what it is that you are looking for is training the community to probably syndromically understand that when somebody presents this, the likelihood is that this is what may be happening. A program, and again, not complicated. Why? Because it has been tested and tried. The ICCCM program that was done among children to sort of like prevent mortality among children proved this case so effectively. And it was done in Homa Bay County. How do I know? Because I was part of it, so I know. Okay? Cascading this thing now so that you are dealing with an adult population, same thing. The very thing you're saying could have been achieved because you're talking about what, over 10 years ago. It could have been achieved, but that absence of consistency in doing what we know we must do. Now, where you work, that place is full of exceedingly intelligent and knowledgeable people who know exactly what should be done. They know. If we do this, it moves here. If we do this, they know. So, when we say we have a problem like the one we have, you have to ask the question, with such knowledge and such expertise, why are we just dwindling around the same spot? Because this discussion, we don't seem to be moving. And yet, there are people who know exactly how to move and exactly how to get to where we're supposed to go. They know. They don't even need to read anything. They'll just tell you, actually, if we did this and did this and did this, this is what we would do.
So how do you address that?
Yeah, so I want to agree with you in quite a number of things that you have raised. Number one, communication. And probably, as you said, as you correctly said, that's where you come in also.
Yes.
Yeah, in terms of ensuring that people get the information.
Yes.
Communication is a very important intervention, public health intervention.
Yes.
And that's why, actually, when I was informed that there is an opportunity to come and talk about this challenge, I said I will put everything else aside and come so that we have this conversation, because I know that you have very many listeners who will benefit from what we have to say.
Yeah.
Because this communication is what now enables people to know how do we go about it. So probably there could be a little bit of a challenge in terms of being able to effectively communicate, which we need to look into. But then another very important issue is what you have said. How do we stick to the plan? Because we have a very good plan.
Yes.
Yeah. How do we stick to it? How do we make sure that we are implementing it 100%?
How do you let people know that this is the plan and this is where we are?
Yeah.
This is the roadmap. At this point, we are at Mtitwande.
Yeah.
At this point, we are at Mariakani. We are approaching Mombasa. How do we let people know so that they travel the journey with us?
Yes.
Yeah.
So
Okay.
you remember in the beginning I said, even SHA is a very good, it's laid out very well. And on paper, if you look at it, it's something that by now we should have been enjoying these, probably we would be at 90, 100%, because things don't happen overnight. But we have spent so much time at the norming stage. We are still having a lot of turbulence. Why? And we are talking about the same things. We all want the same thing. In fact, there are times when we are having discussions, and sometimes they can get really heated when you are trying to implement something complicated. Very many times you'll find that you are in arguments. Sometimes they get heated, and sometimes I just take a step back and I just watch. I say, okay, let me just look at what is happening here, and I find that interestingly, everybody is arguing about the same thing. We all want the same thing. So probably that's why I'm saying we have to reorient. We need to pause and look at how we are implementing, because we have a perfect plan that can take us to where we want. But then it's not moving.
Let me take you back to the plan, and I just want to take you back when you mentioned the Finance Bill 2024, that there were hopes that this would actually make this work, but it didn't, because of course we had to withdraw it. That's basically it. But we had the Appropriation Bill as well, 2024, signed in. The President was very quick on doing that. And I appreciate when you keep saying there has been a plan. There is a plan. We need to reorient ourselves. There is a Health Committee in the Senate that is questioning a number of things, including the debt owed, etc. Now, I want to take you back to yourself and give us, because you said the media need to do more communication, and I just want to hear at least 3 things that you're doing, because you're saying, well, we need to do. What are you doing? Because we no longer have the Finance Act Bill 2024. The courts pronounced themselves that we can proceed with the Finance Act 2023. And now what are you doing in that regard? Because as we're speaking, Kenyans really don't want to hear, and this is honest, that, okay, there is this, these are the challenges, this is where we are. We did the pilot, this is the reality. Now we want to hear exactly, all right, at least in 3 bullets, what is being done at your level that is practical, that you can tell us without just saying we have a plan, that is actually happening, because that's what I've been waiting to hear.
So we have to be patient, first of all. Relax, cool down, breathe.
No,
Easy.
there is no more space for breathing. No, because as we're
I want
speaking,
to encourage you to relax.
no,
Yeah,
it is this serious.
Because one of the challenges
Yes.
is that when we are very impatient and we are very,
How much patience do we need?
we need to relax.
How
and
much
be
more
patient.
patience?
We need to be relaxed. These things, they cannot happen overnight.
All right.
Please, Ankey, I like, I've never heard your name before. This is the first time. So we need to we need to give ourselves space to do this, because it cannot happen overnight. And I think one of the challenges we are having today is because we are trying to rush into things, and then we probably don't get it right. But let's be a bit patient. Number 1, simple things. Let us encourage each other to register. Personally, I am, sometimes, let me just say the truth, sometimes I get a bit frustrated. I say, okay, so how long is it going to take? Because sometimes I'm even tempted to calculate how much I have contributed. And then I start saying, if I was just saving this money somewhere, then it would be enough. Even if I had a very big problem, I would just walk into a hospital and pay. But I say, no, inculcate patience, let things work out, so that at the end of the day, we are all going to benefit, So, first of all, we need to encourage each other that let's register, let us contribute. Like a very big challenge that we are facing now, we have over 19 million people registered for SHA, but just less than 4 million are actually contributing. So you see, that is not what registration itself is not important. What is important is register and contribute.
All right.
Number two, we have also seen, we have actually seen this, that there are some people who have studied. There is something called a means testing tool, which is used to estimate how much you are supposed to contribute per month. And there are some people who have discovered how to cheat this tool. So that even somebody like CT Muga, who probably should be contributing 20,000 per month,
All right.
now ends up filling the tool, and it says now Muga should contribute 300 per month.
Which is a good amount to contribute.
You see, now that is what we need to encourage each other to look at differently, because we shouldn't be looking at it in terms of how much am I losing. You're not losing, you know.
You know, Daktari, the issue here.
Because I'm coming back to the government part role to play. And I understand you're talking more about the public
identifying
role.
where to apportion blame.
No, there's no blame really. No blame really. But
let's all play our part.
We moved from NHIF to SHIF, knowing very well the debts that were still yet to be paid.
Yeah.
So it's not always register, remit, and that's fine. The public
So,
ought to
for
be
example,
patriotic.
like the debts you have talked about,
Yes.
the NHIF debts.
Yes,
Do you know that there is a very active and ongoing effort to pay them?
effort.
Yes,
Okay.
they are being paid. But impatience, you know, I was talking about impatience. Those debts have been there, you know.
Yes,
By the time
yes.
we were moving to SHIF, there were about 30 billion, you see. And there is an active attempt to pay them. But you see, it looks like even this active attempt is the one that is now provoking more animosity. Because now, by just trying to start paying, of course, we are expecting it will take a bit of time. Now, the requirement is pay them now, pay now. We are not going to provide any more services unless you pay everything. So you see,
In as much as we can understand where that frustration comes from.
it is very difficult.
Yeah. Our time, I mean, we wanted to look at one other issue which is critical here. That there's a tier of this funding that will then be, it's a combination of government plus donor funding, and that's where a lot of this freeze comes that will start to cause some kind of anxiety. Not anxiety, but folks are full-blown worried about what's going to happen. The announcement on federal funding freeze that came from the US then threw a lot of countries into a tailspin, and it's at that level now we start to worry. We're looking at palliative care, we're looking at care for HIV, we're looking at many cases malaria, and provision of blood donation. It goes on and on and on. So with a freeze like that, which happened this year, it could happen anytime. What would government do to ensure that even if there is a freeze on donor funding, that it doesn't throw the system into a collapse?
So that's actually, we are now in the deep of that, because we are seeing some real impact of the freeze of donor funding, especially to the health sector. And, we all know that when the current US president came into office, he actually issued some executive orders that impacted heavily on the funding that we are getting from the US. Some bilaterally, that is directly from the US to the country, and other funding through multilateral platforms like through WHO, Global Fund, UNFPA. We have seen quite a bit of funding being stopped.
Yes.
And it's not just a small amount of funding. It is quite heavy.
Significant.
So one of the things that I'd like to say about this is I have seen that a lot of people have gone into a panic. But what we really want to say is that for the general population, they should not panic, because we will do everything within our capacity to ensure that continuous provision of critical healthcare is not impacted.
Where would it come from? If it has been depended upon, if it depends on donor funding. It's depended on donor funding for the very longest time. So the question is, where would it come from today?
Right.
If the donor funding is suddenly stopped, where would it actually come from practically, Daktari? Where do you see it coming from today?
Yeah, so it's a conversation that we've been having for the last few weeks, and we have already identified strategies to be able to plug the gap. Yeah, and actually, if there's anyone to worry about this, it is me and my colleagues, because I can tell you literally there are times we have not slept, gone into the night trying to figure out how are we going to ensure that these services are not stopped. So, and we are actually moving towards being able to plug the gaps. Number one, we have identified that whereas we are saying that the impact of this stop is about 30.1 billion, or is it 31 billion per year, we are realizing that it could be much less. Because take, for example, the support that is going towards human resource. From the records we have found that we are saying we are going to lose 5.8 billion towards human resources for health. But when we now break it down completely and say, first of all, what was these human resources that was receiving 5.8 billion? You find it includes even people who are working within those USAID programs, T-girls or drivers and so on and whatnot, who we might not now have to transition into this new arrangement.
Okay. Yeah.
Interestingly, you'll find that that cost can even go down by 75% when we now say these are the critical HR that we need to be able to continue financing. So number one, we are working on identifying the exact gap, which is going to be much less than what we are reporting. Number two, we are looking at ways of raising some money. Of course, now that, and this is a very important thing. Sometimes it's good for us to be very candid and genuine. Kenya is one of the countries in the global south. Our economies are very fragile. So most of the time you'll find whatever amount of money we have, the resources, there is a very big competition for a lot of things, infrastructure development, education, and so on, very many sectors. So we tend to look at the availability of foreign funding as a reprieve to say, now that there is foreign funding, let us focus on these other sectors. Okay? Now, when we are told that try and put some money into health sector, we say, okay, but because we are in so much need, we continue putting in other sectors. Now we have gotten to a point where the money is not coming. So what do? We have to look for ways of now rediverting some of the money into the health
something
sector.
else.
So there is something that we will have to do around appropriation from the consolidated fund so that we allocate a little bit more, not towards to cover the whole gap,
but at least to fill somewhere.
Towards it. Now, another thing again we are doing is we are actively engaging private sector, local private sector, because we also have billionaires here who can also give the same kind of resources that we are receiving.
Happening on the other side.
Externally.
Dr. Matendechero, it is, our time does run out. Okay. There is too much, and I feel that they need to be front and center of conversations all the time. So, our invitation to you is open to keep coming back and let's look at these things and keep these conversations in the open and not hidden under the cover of darkness.
Absolutely.
Thank you so much for being here this morning.
Thank you.
In the hot seat of Kenya's biggest conversation. Dr. Sultani Matendechero is a Senior Deputy Director at the Ministry of Health, and we've been trying to unpack some of these things this morning. The unpacking continues in a further conversation. Asante sana.
This is The Situation Room, the only way to start your day.